Welcome back to the Physio Foundations podcast for another week where we talk about the knowledge and skills that provide the foundation of expert clinical practice. And this is part 3 of a series on clinical communication. And it's the second part of my conversation with Zuzana, where we're going to talk about applying my 10 tips for clinical communication in the clinic. So Zuzana, welcome back.
Thank you for having me.
So before we start and get into the content for part 3 of our clinical communication conversation, you've just got back from the Sports Medicine Australia conference up in sunny Queensland, up on the Gold Coast. So you had 5 days away there and enjoying the conference and presenting your own research up there. So how'd you go? Highlights and what happened?
Highlights. Well, there was many. I think the main thing is I like going to these conferences, and particularly like a combined one where you have not just physio, so it's not profession specific. So Sports Medicine Australia, you've got all professions encompassed that are involved there. So I always like those types of conferences because I often will purposely go into topics because they often have different rooms going at the same time. So I'll go into topics that, I don't necessarily have a lot of to do with. Like I've gone previously to a cardiologist's specific session and found out a lot about, the athlete and heart issues. I've gone to podiatry ones, and, you're looking at footwear and all of that sort of stuff, as well as other running biomechanics, etc. So that's what I like about going to those specific types of conferences where you've got a whole range of topics, not just really being specific onto the one thing. And also it's that social interaction, and you're able to talk to, and gain new mentors because you can, particularly if there's a specific field of research that you like, often, you'll be going through all this literature and there'll be certain names that keep coming up, and then you go to a conference and there's one of those names that's presenting and you're like, oh, wow, this is so exciting. So it's almost like a celebrity and you're star shocked, but you have that opportunity to then talk to them, and it's really, really nice.
It's such a good career progression to go to a conference. For the young guns listening to this, this is something when you go to your first conference, you won't forget that, and you get to really get a taste for what you could do, what you could really do, not just in your field, but this is a multidisciplinary sports medicine conference we're talking about. And you meet all these different people, you get new ideas. It's a really nice thing to do, and really good that it's back face-to-face, because in Australia, particularly in Melbourne, we lost a lot of our conferences and they went online, and there's something to be said for a live event and the dinners you would have gone to and all the people you caught up with. So I missed out on it, unfortunately. Teaching duties and family duties. But so some highlights I've got on my list were Steph Filbay, the ACL researcher. Hi to Steph from your research group. So her research on cross-bracing for healing of ACLs, really frontier, cutting-edge stuff, where they found 90% of ACLs healed without surgery. So that's stirring things up around the world in many discussions.
Yeah, so that was their initial, and now they're doing a much larger trial as we speak.
Yeah, so watch this space. We had Pat Valance and Joel Martin and Sanam Tavakoli from my research group, Monash Musculoskeletal Research Unit, presenting their research on Achilles tendinopathy. So well done to those guys. And lots of really good papers on hip and knee osteoarthritis and quad strength assessment and rate of force development, all these interesting things. Anything else that you can think of? It's not a conference summary. It's just happened, so we have to talk about it.
There was the Opti knee as well.
Oh, of course, yeah.
So this is a group, so many collaborations, so including my Latrobe and some international collaborations, and they're really specific knee, let me think, osteoarthritis and knee injuries, but they've done a whole bunch of systematic reviews, all published in British Journal of Sports Medicine. I think that's now come out. But I spoke to Jackie Whitaker from British Columbia. so University of British Columbia. And the whole reason for developing this group with this huge interest in knees is to really get other people interested around the world, and that knowledge translation. I mean, it's great if you have a group here in Australia, but how do you get that knowledge out to everyone in the world? And I think that's where they're coming from. So it's really exciting. So you can follow OptiKnee on Twitter, and if you have an interest in knees, it's a really good one. But yes, there was there was a whole bunch from my group from La Trobe on hip and groin, and also your women in sport, and all of that. So that Prep to Play. And some awards have come out of that. So that's always really, really nice.
That's a conference you can follow online a lot because people tweet it out, but you can also see all the abstracts that are published. So I guess for people who are more experienced and into sports medicine will probably be all over this already, and will be enjoying hearing a bit of a wrap of the conference. If you're a young gun or a student, you've never been to a conference like that, that's a bit of a taste of what you can get out of it. And yeah, thanks very much for the summary. Let's talk about clinical communication. Let's talk about what we're talking about on this episode. So the big thing we wanted to go through was mopping up some of the points from last time that we didn't get to, because we took a bit of a deep dive into explanation and the teach back method. So I'm talking about in the second of this series of 3 that we're doing. So this is the last episode. So episode 31 of Physio Foundations. We talked about a lot about explanation and a powerful way to confirm that people understand what you're talking about, being the teach back method. So getting people to explain back to you what they think you've said. And that was something that you went into at length.
Just on that. So, I mean, you've got that teach back method. So really getting that understanding together, making sure that A, the patient has the understanding, and B, that they're going to do something about it, about what you're asking them to do. But one of the presentations, which was quite nice from Professor Jackie Whitaker, was on motivational interviewing. And this is a new push, well, not necessarily new push, but a lot more people are using this particular technique in the clinic. And what I liked about hers was she had, and I've gone back to my notes and I can't find it, but there's a specific method, almost has a protocol attached to it, how you can go through not just the sort of the education, but getting the intervention happening, and but more from the patient's point of view and the patient's motivations. And she had a very nice video of an example of, in one of their studies, how they used motivational interviewing. And so they had the clinician, and then they had the patient, and the patient needed to do some knee exercises. But rather than, prescribing the exercises, it was more, the angle was asking the patient, what exercises do you want to do? And it was interesting because I thought, oh, this is a little bit different. And the patient goes, oh, I've had so many exercises given to me in the past, and I didn't really like these ones and these ones, but hey, I did like, A, B, and C. And also it was really nice in terms of the way that you go about, if they don't know what they want, they have a way of asking the patient to say, saying, well, would you like me to give you some examples of what others have found helps them? And it was really interesting to see, there was a couple of times where that particular strategy was used by the clinician, and the patient just said, actually, yes, that would be really helpful for me. And, they went so specific into the prescription of the exercise, not only, your exercise parameters, types of sets, reps, weights, etc., but also what time of day What days will you do these exercises? What time of day will you do these exercises? And also, what I thought was a really good follow-up question was, how confident are you that this week you'll get your exercises done? And that was, and it was interesting that the patient was there and he said, oh, actually, now come to think of it, these are the exercises. These are the times that I've said I'm going to do them. I reckon I'm 90% confident that I'll do it. I think it's realistic and I'm looking forward to it. And I thought, that's actually quite a nice thing that I might start incorporating as well. So, anyway.
That's really useful, isn't it? So, what exercise would you like to do? Do you want, and if a prompt there, what do you want some examples of types of exercises that could be helpful, and then the specifics of what, where, when, and how, and when they could actually do them so they're realistic. And then how confident are you that this week you'll get your exercises done? So really involving the person in the doing of it. I don't think anyone disagrees that a specific exercise is effective. You might have research for it. It's worked for other patients. It's worked for the person before. There's other things that get in the way of you doing that exercise that you're talking about there with Jackie's research.
And the other thing that was really, really nice was that she commented on, because they have been doing, and like I said, I forgot the actual method, the name of it, but it's under the umbrella term of motivational interviewing. They got the feedback from patients because, listening to it, you think, oh my gosh, this is a bit of overkill. And she agreed, that's her first thoughts. But when they asked the patients that were involved in the study how they felt about it, and I think that they're actually going to do a paper on this, she said there was quite a few that said, well, I really liked how specific they went into, the prescription, and no one's ever done that before. And I feel like that's what's helping me, overcome or, continue, be more accountable for what I need to do.
Interesting, because we often talk about simplifying things. But this is talking about the value or the perceived value of the patient of having things explained in a greater level of detail and personalised to them. So this is Jackie Whitaker. We'll put this in the show notes. Jackie's research presented at the Sports Medicine Australia Conference, November 2022. If you're listening to this in 3 years' time, you find the abstracts for those online. That's a really good little segue there. It took me off my introduction. I was summarising the main points that we did in episode 31 and where we're going in this episode. But thanks for interrupting me with that, because it was gold. Very good. So we're talking about, so in the last episode, explanation and the power of explanation, and how teaching back method and confirming that the person understands you. And then we talked about the patient may not always be ready to hear what you want to say. The power of reinforcing and repeating important points multiple times. Susanna, you talked about hands-on treatment being the perfect time to do some education and explore people's perspectives and goals, using their dead time wisely. And then
if you're doing hands-on treatment,
well,
obviously there's other ways, but as I know, there's some people that prefer not to do hands-on treatment. But there are times where that is what you want to do.
You're taping someone's ankle. You're watching a video with them. You're doing exercises. You're going through sets and reps. There's many things where the intensity of the initial interview or the subjective assessment has died down a bit, and there is an opportunity to talk to the person and understand them. And you talked about using that time wisely. Yeah. And then you flipped jargon on its head. You flipped my point from episode 30 on its head, and you talked about using the patient's jargon that they've brought in with them to help them understand their problem more deeply, which I thought was a really interesting point. And then you talked about in exercise prescription, and how exercise prescription is really, communication is fundamental for a good exercise prescription routine, and the power of humour as well, and bringing humour and not just being robotic and connecting with people through humour. You talked about if someone has brought in a radiology report and wants to talk to you about it, that means it's meaningful for them. So don't ignore it, even if the symptoms and the function and what's on that report may not correlate. So there's a can of worms we could open many times again in the future, but it was a very nice point to think about, not ignoring somebody's concerns, especially if they've brought it in to show you. And then we finished off talking about tips for using literature in your patient education without being someone who's reading from a book and without just appealing to authority. Well, it's in the literature, so therefore he talked about the nuances of using literature in your education. So it leaves us in this episode with points 3 and 5 to 10 to discuss. But don't worry, we've covered a lot of these already, so we're going to rip through points 3 and 5 to 10 pretty quickly, because there's a lot of crossover between these tips. So point 3 was consent. We're going to talk about consent and the 3 things you must get consent for. Even if you think you are, you may not be. We're going to talk about investigating with your communication, which was tip 5. We're going to talk about monitoring the effect of interventions, including exercises, and involving the patient or the client in that process of monitoring. We're going to talk about warnings, which is really related to the expected outcomes of the treatment and to consent as well. Does the person know what they're getting themselves in for? We're going to talk about cueing, verbal and non-verbal cueing in assessment and exercise prescription. Tip number 9 from episode 30 was summarizing what you found and what you think it means and clarifying that people understand. And then we'll talk about tip 10, linking back to the person and who they are and their job and hobbies and work and sport. And is everything you're doing relating back to that person? So let's start with consent. I've put my thoughts on consent out there in episode 30. What do you always get consent for in the clinic from patients?
So what's your 3 things that you must get consent for?
Yeah. So the 3 things that I've already put down as my official word on the matter are touching the patient. You can't touch somebody without consent. Okay? And you can't ask them to take clothing off without explaining why it's important to do so. So it's not good enough just to say, take your shirt off. Even if the person does it, that doesn't mean that they've consented to it. And even if it's, in a football club change room. And now I know there's different levels and degrees and care and caution that you have to take with consent. Underage patients, for example, you would have parents there with you and you may even have written consent for things. I get that. But just the principle of how you ask for consent, I think that's really important. And then number 3, of course, is what you're doing. Hopefully, there's no one listening to this who would just start doing an assessment or start doing a treatment with somebody without really thoroughly explaining to the person what they're trying to do, why they need to do it, why it's important, and the risks. And so the 3 things being touching the person, exposing the part, and doing the procedure or the assessment. What would you add to that?
Well, I mean, I had a patient the other week, and I get a lot of people refer to me for hip and groin stuff. And this lady has seen a lot of different professionals for her groin-related matter. And it was interesting, she did have, bike shorts on. But, I'm feeling for things like the adductor insertion and, on top of the pubis, etc. But I will always ask, is it okay if I have a feel around this area, and I'll point it out, and then just, go for it. And then, of course, I always compare sides. So then I'll go to the other side and say, now, is it okay if I do it on this side? So go for it. And then, we did some assessment, some treatment, and then I did some reassessment. And again, I said, do you mind if I have a feel through here? She said, yeah. She goes, thank you so much. No one's ever asked. And she said, and so many times, which, because I'm quite ticklish down there. So it made me be able to prepare myself.
Isn't that interesting?
Yeah. So that was the first time someone said that. And I just thought,
thanking you for doing what you need to do from a medico-legal perspective, which is get consent and explain what you're doing and why you're doing it. But sure.
But it's also that I'd repeatedly sort of, offhandedly said, is this all right? She also enjoyed that. So I thought, okay. So don't just assume that when you've asked them once and then you're going straight back into maybe a vulnerable position or a vulnerable, because a lot of times, we might have to put someone's leg up in the air and, they're not adequately covered, for example, women wearing skirts, or even just if you've got them down into shorts and they're short shorts, sometimes people don't want to see that, or you're pulling people's shorts down where you're going to see their top of their bottom, or even things like bras, etc. When it comes to that, if I'm anywhere near that, I say, is it all right? Are you comfortable? And so I agree with all the clothing and all of that sort of stuff. And also, I think with the consent with treatment, I think that's very important, but also giving them the options of treatment. So we can do this. And this is what I would prefer to do, but there's also these other options if you want to go down that way. So, like if you were to do something like dry needling, here's this option, but hey, we can do this and that, or we can just do some exercises and see if that can change your presentation, etc. So giving them, asking them, hey, this is what I want to do. Yes, can we do it? But B, also, giving them the options of other treatments can make a big difference too, just to add on to that.
Yeah, well, so asking for consent, if you say it in terms of the requirements and things you have to tick off, it does sound like extra work. But what you've just said there is you developed rapport with somebody and let them know that you understand what it's like to be vulnerable and to be a patient as well. And to the point that they thanked you for it. I think that's telling. I think that's really important, and it really supports what I'm saying about this. The enemy of consent is assumption. And in many ways, it's your knowledge, the curse of knowledge. You know what you're doing and why you're doing it. All of a sudden there, you're palpating, I think you said the adductor tubercle and the pubic symphysis of somebody. Put yourself in their shoes. What does it feel like if someone starts palpating, especially if those spots are tender as well, without telling you why they're doing it, without explaining it? Now, of course, that's a really obvious example. Hopefully there's no one listening to this who wouldn't really explain what they're doing, why they're doing it, get consent for that. But I would widen that to any area of the body before you place your hands on anybody. Don't assume just because they've come in to see a clinician practitioner that they've given consent. And I don't think it takes long. It's really tied into you want to sort of explain the main problem, you confirm the history, this is what I'm doing, and explain why you need to do it. So in other words, or for example, Zuzana, I'm going to assess your shoulder today. And in order to actually have a feel of what's going on in there and feel where the restriction is, I'm going to actually ask you to take your top off. Are you wearing something appropriate underneath? Yes. Are you comfortable to do that? Good. That will allow me to see how the muscles are moving. I'm going to use my hands as well to have a bit of a feel of the movement. And then we're going to do some tests that get me a bit of a measurement of how stiff your shoulder is or how weak it is, for example. The person knows what's coming up.
And why you're doing it.
I just think we, so the enemy of consent is assumption. It's the main point from that one. But let's move on to point 5, investigate with your communication. And this is really something that you taught me over the years. And having an ongoing conversation, an investigation with the person of what you're finding, what you think it means. So ongoing explanations of what the tests you're doing, what they mean, what you're finding and what you're thinking, and involving the person in the process. So since you taught me that one over the years, or you're the main person who really showed me the value of that one, what are your thoughts?
Well, often I'll do a test and I will talk to them about what I'm finding there. So, for example, I'll always go do the good side first, or the better side, I should say. And then I'll go to the problem side. And as soon as I find something that I'm thinking, there's going to be an asterisk here, this is something I might want to reassess, I'll let the patient know. So let's just say, hand behind back, maybe for a shoulder, or internal rotation for the hip, or something like that, where you do the one side and go, okay, that's what it should feel like on the other side, and it doesn't. And I'll go, okay, can you see how that's a lot stiffer on this side compared to the other side? And a lot of the patients will look at me and just go, no, I don't see. And I'm like, can you feel it? Not really.
Okay.
And so then what I'll do is I'll go, okay, that's interesting. And so I'll go back to the good side or the better side. And then I'll show them. I'll say, see, this is what's normal for you. Can you feel that? And they're like, yes. Okay, now let's go back to that other side. So I'll repeat the test for them. And they're like, oh, yeah, I see what you mean. And it's really quite valuable for them because that way, when I do some sort of intervention and then I reassess, they've already got that baseline feeling of what it was like before we did it. So they'll actually see if things have changed. So it's not just me writing down some numbers and telling them, oh, look, that's better. They actually go, oh, yeah, that is better. Or, like a straight leg raise or a slump test or whatever you're doing. But if I do find something or if you find something that you're going to want to reassess, let them know and really highlight it. The other thing that can be very, very powerful is if like for example, I like to, just test high hip flexion whilst the person's sitting. So I'll get them sitting with their thighs supported and then they'll lift up the thigh, about 45 degrees, but and then I'll push down and I'll say, okay, just a quick, I guess, strength measure. But it's
like resisted static, willingness to push sort of test, yeah.
Yeah, and they'll go, okay, yeah, that was a little bit difficult. And then I'll just start laughing and I'll just say, now I'm interested to see how you go on the other side. Good luck, and they're like, what? and then they can't resist me more than likely. Yeah. So about 95% of the time they can't. And they see that weakness on that side straight away. And it's not necessarily a true weakness because I'll do some intervention and then we'll go redo the test and hey, now they can resist me quite easily. So, that activation and all of that sort of stuff. So, but if you can sort of almost predict what's going to happen, like even calf raises, let's do your good side first. I reckon you'll be up and that's where knowing the literature, knowing where normative values sit can be very powerful because you can refer to them also and say, look, this is what I'm expecting. Let's see how you go. And if you say it before a test, it's a lot more meaningful than after the test because they've already got a number. And so if they then fail to reach that number, they're already like, oh, okay, this is something that I'm going to have to work at, and which really ties nicely into whatever you then decide for your intervention, because they can already see that they need to work on something and they can already see that the next time they come in, you're going to be testing that, and it gives them the motivation that they want to be better at that test the next time they see you. And I'll often say, now we've got a test to show whether you've done, whether you're going to do the exercises or not. This is really up to you. And it's nice because they'll come back and if they haven't done what they needed to do, they're pretty upfront with you straight away and the reasons why not. And it's rather than sort of saying, oh, yes, have you done your exercises? Yes, I have. And they're just trying to do that clinician pleasing. And then you test them and you're thinking, hang on, assessments are about the same as the last time I saw you. So getting that rapport and that confidence or allowing them to have the confidence to tell you when they haven't done stuff is also good.
If I could summarise, so that's point 5 and 6 covered there. Investigate with your communication and then monitoring the effect of interventions. And if I could summarize that in the sentence, it would be involve the person in the process of assessment and treatment. So it's really helpful. And then what about warnings? This is point 7, warnings. We talked about, I did in episode 30, the communication aspects of warnings. So obviously there are minor and major things that can go wrong. Everything from the risk of soreness to the risk of being uncomfortable during a procedure for many, many different ways that you could be uncomfortable, through to more serious risks How do you approach giving warnings to people without frightening them?
One thing that I often tell patients is, let's see how you go. And if you're better, that's great. And it will tell us what we need to do, like we're going in the right direction, etc. But if you're worse when you come back, that's not necessarily a bad thing. Because it could be that we're in the right direction, but we've just done a bit too much. Or, maybe we need to redefine what we're looking at, and then we can go at a different approach. The worst thing is when, I'll see a lot of people that have seen other clinicians and haven't necessarily got a good outcome. And by and large, what I see is the same intervention was applied with the same result. So there was no progression. And then the same intervention again, no progression, same intervention. And you get this going. And the thing is, the longer this person is in that sort of rehab cycle where things aren't improving, the more complicated their presentation is going to be, because you're going to get things happening, at that higher level, that chronic pain, the mental health, the social implications of that. They're not able to say they're doing tennis and that's their own social outlet. And now they can't play tennis with their friends, or they can't go for a run in their morning with their running group, or whatever it is. It can make a huge difference the longer they're in that rehab. I mean, I know at a professional sports level, athletes are there because they're so good at their sport, whatever, this chosen sport is. But often growing up, it's that sport where, when things weren't the best, that was their outlet. Or, they got stressed, I'm going to go and play a little bit of cricket, or I'm going to go and run on the beach, or I'm going to get on my bike, whatever it is, exercise has helped them through things. So the longer they're in the rehab sort of cycle, the harder it is for them, because, they're used to doing their sport, and if they don't have that, so you've got to acknowledge the mental health as well. And the worst thing is when people get out of that rehab cycle and now they're going back to sport or performance, or even if it's just activities of daily life. The biggest thing is you want to have enough sort of rapport with your patient, and you want them to have enough confidence in you that if they fail for whatever reason, so they have a reoccurrence, so let's say it's low back pain, for example, that they come back to you, so that, you've got a plan, and getting them to self-manage. Because the worst thing is you've done this really good bout of intervention. Let's say you've done really good education and intervention, and then they go off, and then 3 months later they have a reoccurrence. They're going to think that all that stuff that they've done with you has been for nothing, and then they'll go off and see another professional, and then they can be in that cycle. But if you've already educated them that, hey, this is really good what we've got here, we've got you back to, you've ticked off all their goals. But just to let you know, with particularly, say, low back pain, you've got a high risk of reoccurrence, and this could happen. And so now you have an idea of what you can do in the early phase. And that's why often what I'll get patients to do is have just a couple of tests. And that's why I always find, a couple of tests that they can do at home. And particularly if they're at a high level of sport, or if they're in that sort of older age group, so middle age onwards, I'll often get them to do 1 or 2 tests that they do every day to monitor. So monitor their back, monitor their hip, monitor their shoulder, whatever it is, because if they do it every day, they'll know a difference. So say, I get them just to do lying down, do a couple of back extensions. So one morning they'll do their back extensions. They feel fine. Great. Off they go. The next morning, now they can feel that their back is stiff. Now they actually have an opportunity to do something about it. So they might go do some stretches, etc., and reassess, now my back's good. Now I can go on with my day. But it also gives them time to reflect on what is it that I did the day before that's possibly given me this stiff back. So then they know what activities or what things affect their back. So they could have been, they've gone on a holiday and they've been sitting in a car or an aeroplane for a long time. And it's like, okay. And so then next time that they do it, before they go to bed, they might, or once they get to the hotel room, they might just do some stretches on their back so that they don't wake up the next morning with a stiff back. Or they might have overdone it doing gardening, or it might have been they played a different sport. Or having said that, they might have a day where they wake up in the morning and their back just feels fantastic. So I always tell them, this is the worst case scenario. You'll figure out that, but also you want to know what your back likes to do. So it's like, hang on, I went surfing with my friends and I had a fantastic time. And now, look, this back feels really good. So maybe the surfing is a good thing.
You're tying the warnings about what can go bad in with that reflection about what can go good, what can work.
Yeah. And then more importantly is when, I'm about to discharge them, I'll say, now that you've got this test and then you're going to do it every day for the rest of your life. And I really put it in there because particularly for backs and other presentations, but if they get that in their head, they're like, now I know how to manage it. And if, you have, it's restricted, whatever test, if it's restricted for quite a few days and you've done all the things that we've talked about and that hasn't improved it, that's the time to go see someone and do more like a preventative. So don't wait until you've hurt your back again. Does that make sense? So they're really active. So it might be, I just can't loosen up the back. I can't get that full lumbar extension. They go see you once, you've got it back, and there you go, rather than waiting for, now their back's stiff and sore and off they go. They play a whole game of golf, which is a lot. And particularly if they don't have the range there and if they don't have the range now in their hips as well, that can have, they're on the floor the next day and they're like, I didn't even know, why has this happened to me? Or, it's because usually it's a little thing that they've done that will flare up a back, and then they'll think it's because I picked up that little bit of hair off the ground. I was like, well, no, I'm pretty sure that's not what's.
However, what did you do for the week beforehand? Yeah, and you're getting people to by taking many instances of measurements daily, as you said, you're getting people to reflect on not just what they've done that day, but also what they've been doing across time. And it's what struck me about that was your emphasis there on empowering the patient to do their own measurements, do their own reflection, and do their own education. It's really important. Let's see how you go was your question. Well, rather than giving them an answer, this is what will happen. Let's see how you go, and you're going to try this, and you're going to reflect on it, measure it, reassess it, and come back. And then you're going to stabilize somewhere and figure out where, how you can manage this yourself.
Yeah, and often I'll see these patients later on, and they'll be dictating to me what they need. They'll be like, "Yep, this is what helped. When this particular thing happened last time, this is what I need from you. That helped a lot." And then you only see them once or twice, and then it's like, "Yep, see you later." Which is, it's really, really nice. And I think I've learned that from a couple of my patients early on in my career. And these were in their 80s. I can think of two off the top of my head that it really struck me. So one man, he had really, really bad back pain in his 60s. And he really struggled with it, saw multiple clinicians, and then ended up with a chiropractor. And the chiropractor said, "Hey, you live by the beach, don't you?" And he said, "Yep, I do." And he said, if you swim every day, regardless of the temperature, you will find that your back will be happy and you won't need to see me or anyone else. Well, not necessarily ever again, but the fact that he then did, that's what he ended up doing. So he'd do a couple of stretches in the morning and then he'd go swimming. And I saw him not for his back. He said, he was in his 80s. He'd never had back pain ever again. I was actually seeing him for his hip. But I just remember, because this is where, you get these funny moments where then, I was like, "So how was your swim this morning?" And this was in the middle of winter and this was in Adelaide, so southern Australia. So the water is quite cold. He said, "I only lasted 5 minutes." And I just went, "Did you wear a wetsuit?" And he said, "What's that?" And so we went in and I said, "You can get gloves as well," because he was really talking about his hands being really sore. And then the next time I saw him, he said, "Oh, thank you for that. I spent, an hour swimming this morning and I got this brand new wetsuit and these nice new gloves. And hey, it's helping my hip as well."
What a legend. Wim Hof was there as well and he only lasted 10 minutes. So that's good.
But that was good. And then I had another guy, same thing. He has his routine. And again, I know people like funny stories, and this is quite a funny story because I actually saw his wife, and I knew where they lived because I could see the address, and I knew the house, and the house was well known to the neighbourhood because it backed onto this sort of walking trail by the creek. And anyway, I got talking to the husband, and he said, he also has back pain, etc. He goes, "But I've told my wife she needs to do the exercises every morning with me." And look, this particular gentleman, he had his back pain again. Same thing. He was in his 80s and he had this real bad bout of back pain in his 60s. Was given, it's just 5 minutes of these particular stretches that he would do every morning, and he was able to manage his back or, the whole way through till, when I saw him, and he was still going fine. I was seeing the wife. But the funny thing is he was well known for these stretches because he had a 2-story house, and where he did these stretches was in this full-length window where if you were to walk past, you'd see him do it in his underwear. So, and I must admit, I have seen him doing his stretches in his underwear. He just doesn't
care. This is where I stretch.
But
this is my morning routine.
He was able to manage his back pain, and good on him.
Gold. Where you're telling me these stories, and it's reminded me because we've known each other since we've been new grads, and I remember as a new grad treating a patient. I think that had a flare up of some sort, and I'd taken it personally. And you said that to me. You said the same thing. You said what you say to people is if you're getting worse, it's not necessarily, or you get worse after an intervention or after an exercise. It's not necessarily a bad thing. So it may mean that we need to reevaluate. It means that you understand now the effect that has. Maybe we did a bit too much. Maybe you need to do more of it. Maybe we can take a different approach. I found that quite stress relieving as a new grad to know that it's just a process. It's like a thermostat on the wall. They're measuring the temperature. It's going to be too high, too low, and we can eventually find a sort of homeostasis, a midpoint there, set point, and which is what you're talking about. We're getting people to do a daily measurement and empower themselves with that information, and they see the patterns. And it's beyond, this conversation started with warnings. Point number 7 was warnings, giving a clear warning to somebody. And your points were really valid about warnings. Let's warn people about the fact that if low back pain is really prone to reoccurrence, it's probably going to come back at some stage. So they understand that, the bigger picture of it, not just what's happening right there.
And they have a plan for when that does occur. That's the biggest thing.
Yeah, definitely.
So knowing it could happen again, but to be really confident in what you've been able to give them is you've also given them a plan. So your management doesn't stop till when they get to, back to everything. It stops when they've got the knowledge of, what it is that they've got and what they can do if it happens again. Like, it's really, really important. I mean, if you look at all the sporting literature and a lot of, the musculoskeletal stuff, a lot of the risk factors of injuries are if you've got a past history of that particular injury.
Mm.
So, yeah.
So that's a part of your warning, is that this is more than likely, it's possible that this will come back. So the person is prepared and they know, and they can be invested in that outcome and trying to prevent it themselves. Yeah, that's really gold. We've covered items. It sounds very formal. Tips 9 and 10 already. Tip 9 was summarizing what you found and what you think it means, and really clarifying people understand and involving them in the process of assessment and decision making. And then tip number 10 from episode 30 was linking to the person and their condition, which is something you've been talking about for the last 40 minutes or so. So knowing the person and knowing what makes them tick and their job and their hobbies and sport, and relating what you're doing and the outcome to the person and giving them that ownership of what's going on. If we jump back for a final point to point number 8, which was cueing. So I talked briefly about this, the importance of verbal and non-verbal cueing. This is something that's a bit of fun. It's something that you often talk about in terms of giving people novel, funny cues to get them to realize the way they're walking or the way they're doing an exercise. Tell us a bit more about how I guess the verbal and non-verbal ways you cue people to move well and to do exercise as well.
I think just understanding that people learn in different ways, that they do talk about, the ones that are seers, doers, feelers, all that sort of stuff. And there's other things that is out there of how we learn and, through practice, etc. But giving the opportunity to learn in multiple ways, which means if you're going to give an exercise as an example, talk about the exercise, so describe it, then show it so that they can actually see what it is that you want them to do, then get them to do it so that they can feel it, and then give them some feedback. So whether that's, you might be giving them some manual feedback with your hands, you might be giving them visual feedback, with some mirrors, etc., or it might just be verbal, and then give them the opportunity to ask questions. But it's also really important, particularly if you're giving people exercises, is to ask them, where do they feel it? And is that where you expect it to be? Yes, ask about their pain, but try not to focus too much on it. Like, if you're getting them to do something which you're expecting them not to flare up their pain and you're asking them about their pain, it's almost setting them up to focus on the pain rather than the exercise. So often, I'll say, I don't want, this to be painful, or I am expecting a certain amount of pain, but what I don't want, so I'll talk about what I don't want, and that is, I don't want the pain to get worse, and I don't want it to change. So let's say they've got a dull consonate. I don't want that to get sharp or the intensity to spike at any point. So if they just concentrate on those things, that doesn't get worse and it's not sharp pain, then we can leave that pain in the box and just focus more on the intervention. And even because the other thing that we need to, because, pain is a big thing, and, the pain science, there's a lot of research into it, etc. But what I find is, pain may be the last thing that improves. So, don't necessarily focus on it. So when you're cueing someone and you're giving them all the right things, and they're doing what you want them to do, it's really powerful to then reassess some of those points that you feel that your intervention or that exercise is going to improve. And then when they see that it has improved it, despite them feeling pain, they're like, and they get more confidence with doing that exercise or whatever intervention it is that you're going to do with them. And then it gives them not just that confidence, but that motivation to keep going with it because they can see it. And I think one of the powerful things that I got, and this was from Joanne Kemp, who's a big person in the hip world, and she's at La Trobe as well, and is one of my mentors. I liked how she put it that sometimes the intervention, so let's say a specific exercise, that can be just as powerful as pain medication. So you talk to them about, let's say your knee hurts and you take an anti-inflammatory and it gets better, let's do these exercises or this 1 or 2 exercises and, look, your knee's better. So you can take them in the same way in that it hurts, I'll do a couple of exercises and, which is the same as, okay, it hurts, I'm going to take a couple of pills and that improves it. And then they're more active in, trying to resolve what they've got and they get better outcomes.
So there is no 5 minutes here allocated to patient education, whatever that is. What you're saying here is almost everything that's happening from the very first interaction with the person involves this feedback loop of communication and education where your end point you're trying to get to is empowering them to manage themselves, which is what you want. And then you can make your money from the rather than endlessly over-treating and over-servicing this person for the rest of their life. They can get better, self-manage, and recommend you to someone else who you can help. So much more and positive way
again,
to look at it.
This is probably stuff that I learned early on because look, I used to work. We've done a podcast about my career, and I've worked in multiple settings, and one of them was in work cover, so looking at work injuries in specific factories. So I was in a chicken factory, and I was also in a car factory and an electrical factory, and I was even went to a winery at one point because they were getting a lot of low back pain from collecting the grapes off the wine. But what is really quickly evident is you'll have people that go on work cover because, yes, they've had an injury at work, and you can get those people that get really angry at the system. They feel that work has given them the injury and work has to pay for it, and that's not a healthy way of being because you can see how they develop chronic pain very quickly.
There's some unhealthy emotions in that thought process of resentment and some things that are never going to be a healthy place to hang out. Yeah.
Yeah, and then you've got the other ones that are embarrassed about being, that they've hurt themselves and they just want to get it all right so that they can just get back to how it was, and they tend to be really, really quick. So often what I would do is because people can become dependent on the clinician, and I've seen this particularly in work cover because they'll go and they'll go get them, let's say their massage, or they'll go do their hydrotherapy, and that's the only thing that helps their pain. And so then they become dependent on, well, I have to go to my appointment because that's the only thing that's going to help my pain. So I often will get those types of people and say, look, I'm glad that I can help you within the session to improve you, and I do care, and I will care when you're here. But I don't live with you. I'm not that person that's always with you. You're the one that lives in your own body, and you've got to take charge of it so that when, things aren't going right, you need to be the one that looks after yourself. Because I think sometimes they just get too dependent on others trying to help them because they feel like it wasn't their fault. And a lot of times it isn't their fault. No one wants it. But if they understand that, hey, it's themselves that are going to get themselves better, sometimes that can change them pretty quickly on which track they go down.
building people's confidence and motivation to keep going through building their understanding. They're your words that I wrote down. I thought that was a really nice way to summarize what you've said there. There's so much in there that we can all learn from and apply. We've got through our 10, or at least our commentary in 2 episodes, last 2 episodes, and commentary on my 10 tips for clinical communication. And you've taken those and applied them and taken them a lot further than I did. So I'm very grateful. And we're going to leave it there. So anything else you want to
add? Exit signs. They're on the way out.
Okay, here we go.
And Velcro, which is this water ripper.
Okay.
And that's what we have today.
There's more where that came from. Lucky we can edit this stuff out. It's good. But it's good fun.
I've got one more.
Help.
Why did the kids take a ladder to school? Because they went to high school. There you go.
Very good. We've got a whole episode of that stuff coming up in the Christmas holiday special. But everyone, if you made it this far, you've done very well. And you've had Zuzana to listen to this time, which is always entertaining, and we're very grateful for. Well, I'm very grateful. I'm sure you are, for Zuzana coming on and sharing her clinical expertise, and that was gold. Thank you. So now it's
actually one more thing. The one thing, like, my approach is just have fun in the clinic. You know, the best thing that I've ever learned was when I was a student. I was put on a placement with other students that had memorized the textbook verbatim, and I was not one of those. And my confidence was low because the tutor would ask questions and they were like bang, bang, bang with facts, with knowledge. And then, I'd be there going, I don't know. And so I was feeling really down in the dumps. And one of my friends said the most powerful thing to me, and I've kept this to this day. And he said, don't worry about it, Zuzana. What you need to do is learn from your patient. The person that's there in front of you, learn from them, and make it fun. And that's what I've done. And I must admit, I love my work, and I enjoy it. And I think that's wise because I'm there. I'm focused on the patient. I'm focused on what they're coming in, what's their history, why have they got this issue, what can you do to make their lives better? I mean, let's be honest, that's what you're doing, is making their life better by them not having to think of all the things they can't do. You're there to show them what they can do and what they can get back to.
That's brilliant. That's a great way to end it.
Merry Christmas.
Oh, Merry Christmas. It's coming soon, November. Learn from your patient. Learn from the person in front of you. There's some wisdom right there. So everyone, you've got plenty there to put into action in the clinic or in your education and in your own journey. So I hope you found that as helpful as I did. Please let us know what you think. Connect with us via all the details that are in the show notes. Leave me a comment or send me an email. If you want to continue the conversation, please do, and share the episode with a friend. But until next time, this is Zuzana and Luke wishing you all the very best with your studying, professional development, and lifelong learning.